All right. Good morning, everybody. Happy Friday. Thanks for joining us as always. We are still moving forward with our faculty presentations, which will be the case for probably the next 5 or 6 presentations before again switching back over into our fellows presentations. And like I think I mentioned in the prior talk, if there's any fellowship directors, program directors that have an interest in having your fellows potentially present as part of the case series, please just shoot me an email with their information and your information as well, please. All right, so today we are lucky enough to have Wade Johnson. So Wade's a sports medicine physician and the chair of PM&R at Mayo Clinic Health Systems in beautiful Mankato, Minnesota. He completed his residency out at New York Presbyterian and a primary care sports medicine fellowship at the Mayo Clinic in Minneapolis. He is the head team physician for Bethany Lutheran College and provides coverage for US Ski and Snowboard and USA Hockey. Wade is excellent at not only ultrasound, but also teaching. I always try and hop on any talks that Wade is giving, so I'm sure that this will be excellent as all of his talks are. So with that, Wade, I will let you rock and roll and you can just take over the screen sharing.
All right, thanks, Ryan. Thanks for that introduction. I'll try and live up to your hype there. Let's see here. All right, so good morning, everyone. Thanks for coming and thanks for taking the time to listen out of your day. Today we're going to be talking about a case of heel pain in a 47-year-old runner. I have no disclosures. We're going to review the protocol for evaluation of the posterior ankle. We're going to review images of a complete posterior and medial posterior and medial ankle ultrasound. We're going to review the pathology associated with this case specifically and discuss and review contents of the diagnostic ultrasound report. Now, for our case history, this is actually a 47-year-old runner. Sorry for the typo there. She developed left heel pain about 4 years prior to arrival. She was running the New York City Marathon, got pretty severe heel pain afterwards. After she finished the marathon, she was really happy with what she did, so she decided to take a break because of the pain. She tried over about 3 years off and on to return to running, but really tried to attempt getting back into running about a year before she presented to me, trying to train for a marathon, but every time she would really get up over about 5 miles a week, she would develop this severe heel pain. Initially, it was bilateral, and with kind of some rest and activity modification, it did predominantly present on the left posterior medial heel. She didn't have any radiating symptoms distally into the foot. Pain would get up to about an 8 out of 10 and really limit her from doing even daily activities after she would try to increase her running. She did have some pain-free periods, especially at night and early in the morning. No pain first getting up out of bed. She described it as a throbbing, aching, sometimes burning. There was aggravating factors would essentially just the prolonged walking, attempted running, and she was an avid curler too. And every time she would try to do this, especially pushing off, she would notice some pain there. Rest was really the only thing that alleviated it. She had tried over-the-counter oral anti-inflammatories and analgesics without really any benefit, and tried ice and those kind of things without any benefit as well. The only prior treatment she had before showing up to me was chiropractic care for around 5 months. Pretty common in my region for patients to see chiropractic medicine before they present to sports medicine. She hadn't had any prior PT or any interventions. And important to note, she didn't really have any numbness in the foot at all. It was essentially all just a pain phenomenon. On exam, she had a non-antalgic gait. She was able to heel and toe walk pain-free. Her range of motion in the ankle was slightly reduced beyond what I would expect. So she was able to get to neutral in ankle dorsiflexion with her knees extended and got +5 degrees of dorsiflexion with her knees flexed. On palpation, some slight non-tender nodular swelling over the mid portion of the Achilles, but not anything that was reproducing her typical pain. She had a slight Hageland's bump on the back of the heel and had mild tenderness over the Achilles insertion, but no tenderness, again, more superiorly along the mid portion. She had no tenderness kind of over the medial or lateral calcaneal tubercles, and no tenderness along the arch or more distal end of the foot. Negative Thompson test and Taylor tilt. She did have a positive too many toes sign when standing. neural exam was essentially pretty normal. She had negative Tenels over the superficial and deep perineal. Strength, again, was 5 out of 5 distally in the foot. She did have pain and reproduction of pain with palpation kind of over the medial heel, over the tarsal tunnel. But her slump test and straight leg raise were also negative. On her imaging that she had before she saw me, really essentially normal ankle x-ray imaging, a little bit of a calcaneal spur at the insertion of the Achilles tendon, a little osteophyte and thesophyte there, and she did have some enthesophyte at the medial calcaneal tubercle at the insertion of the plantar fascia on the plantar surface of the foot. But overall, pretty normal imaging. So when I was seeing this and kind of evaluating her, my working diagnosis was essentially potential insertional Achilles tendinopathy, retro Achilles or retrocalcaneal bursopathy, potentially something like a tarsal tunnel, medial calcaneal or Baxter's nerve impingement, and so my initial management, first, because she really hadn't done much other than chiropractic care, I sent her for physical therapy. We tried a trial of topical and oral anti-inflammatories, more regimented, and I tried a gel heel pad for activity. She completed 4 weeks of physical therapy and really was not getting any relief with this, so we proceeded with a diagnostic ultrasound. Now, when we review the scanning protocol here of a complete posterior ankle, the things you want to look at, obviously, on any complete scan, you want to look at tendons, bursa, muscle, joint, and other soft tissues that are pertinent, including nerves. So for her, we looked at the Achilles tendon, Plantaris, retrocalcaneal and retro-Achilles bursa, posterior tibio-talar and subtalar joint, as well as the plantar fascia. And then the structures that you don't always have to, depending on where their symptoms are presenting, would be more optional, would be the things like the tibial nerve, medial lateral plantar and calcaneal nerves, and sural and potentially saphenous. So starting off with the Achilles tendon, the Achilles is composed, obviously, of the 2 heads from the gastroc and the soleus, and then they blend together, forming the Achilles tendon, which inserts at the calcaneus. The gastroc, there's the 2 heads, and the medial originates behind the supracondylar line, or the and adductor tubercle, and the lateral head originates kind of at the lateral lip of the linear aspera above the femoral lateral condyle. Usually if I'm evaluating a gastroc for more posterior knee pain, I'll look for a flabella as well. But when we're looking at the ankle, I don't always look at that, and I generally start from the myotendinous junction. It's important to note that the soleus, obviously, it does produce more of the tendon that makes up the Achilles. And then at the insertion point, you have the retrocalcaneal bursa and the retro-Achilles bursa as well, between the Achilles and the overlying fat pad and subcutaneous tissue. So when we look at the Achilles tendon here, on the left, top left, you can see we're starting at that myotendinous junction with the gastrocnemius and that superficial portion, kind of going into that gastroc aponeurosis and that free gastroc aponeurosis, which eventually goes to form the Achilles tendon. Coming a little bit more distally and gliding down, as you can see by the little graphic there. We're gliding distally, and we still have the soleus muscle fibers coming in through here, inserting in that deep portion. And you can even see that little fascial plane between the two. And then getting even more distal, that Achilles tendon is starting to form and thicken out. And then even more distal yet, before the insertion, you start seeing kind of Kager's fat pad coming in here, and the tendon thickening a little bit more. And this was where some of her nodular swelling was. Here, we're starting to see the insertion of the Achilles tendon, and you can see the calcaneus coming in the bottom right of this picture. The video here playing on the bottom left is showing kind of scanning medial to lateral along that Achilles tendon, trying to visualize the entire tendon, making sure you're not seeing any abnormalities through that area. And you can see her tendon looked really nice and uniform. More at that more cephalad portion of the tendon, you do see a little darkening and thickening, and that would fit with that nodular swelling that I was appreciating on exam. And then I always look for hypervascularity, neovascularization coming from Kager's fat pad in there that could be causing some posterior heel pain and some Achilles tendon change. But again, she didn't have any of that going on. Then we start getting to the insertional aspect of the Achilles, and you can see her Achilles tendon coming into the insertion on that calcaneus, looking really normal and healthy throughout that area. Again, kind of looking medial and lateral, going through that insertion, looking for any significant abnormality. And there's that at the very end there, you see that kind of that small calcaneal spur that we saw in the X-ray. But again, overall, really nice, healthy looking tendon tissue at that insertion. So then after I look in that kind of long axis view on the Achilles tendon, I'll switch over to a short axis view and again start at that myotendinous junction where you see the lateral gastroc to the left here. And the medial gastroc has started to blend in already in the soleus deep. And I scan distally, and you just look as that soleus is coming in and forming that full Achilles tendon. And then on the bottom left here, it's that Achilles tendon more distally coming towards that insertion. You see that calcaneus at the end. And then this is the Achilles coming in and inserting on that calcaneus. So I really follow it from that myotendinous junction all the way to its insertion. The retrocalcaneal bursa is what I'll look at next. And as you can see on the top left here, she did have a small effusion within that retrocalcaneal bursa. And then I will generally kind of dorsiflex and plantar flex the tendon to put it under more stress, because sometimes if you have too much dorsiflexion on there and too much pressure, you can push fluid out of the bursa. So it is nice to do that. And forcefully dorsiflexing can also show if there's any tearing within that deep portion of the tendon that can kind of mesh in with that retro Achilles bursa. So I'll do that active or that passive plantar flexion, dorsiflexion to evaluate that bursa a little bit better. Then the next structure I look at is that retro Achilles bursa. What you can see on hers, there is a little bit of thickening and hypoechogenicity of that retro Achilles bursa. I'll usually put some Doppler on there to evaluate for any hyperemia in that area too. And on hers, there was that thickened bursa, but it didn't really have any hyperemia or any neovascularization. And again, palpation directly over this spot did not really reproduce any of her typical pain symptoms. But the important thing when you're looking at this retro Achilles bursa is kind of getting a nice gel pad and floating that transducer. You can kind of see the black here above that skin, so you can make sure you're not compressing that bursa. Otherwise, it is an easily compressible structure. So you really want to be able to float that transducer and really apply some light pressure there. Then I look at the plantaris tendon. That plantaris tendon is another structure that transverses that posterior ankle, starting kind of more at that lateral supracondylar line on the femur, and then it transverses, as you can kind of see here, medially along the gastroc and Achilles tendon. And as it's going through that posterior compartment, it transverses through between the gastroc and soleus here. You can see the more distal gastrocnemius portion of the Achilles tendon here, and then the soleus deep, and that little kind of slip right there is where that plantaris tendon goes. And it actually inserts independently on that medial calcaneus down here of the Achilles tendon. And often with Achilles tendon ruptures, that plantaris tendon is intact, and that can sometimes give you a kind of a false appearance of a partial Achilles rupture as opposed to a full rupture. If that is intact, you can still get some active plantar flexion. And then we kind of scan that all the way from that myotendinous junction distally again to the calcaneus. And here's some video of that. So there's that plantaris tendon. As I'm scanning distally towards the calcaneus, you kind of see it moving more and more to that medial aspect and getting over here to that medial aspect of the Achilles tendon. And then I will scan that all the way to the insertion on the Achilles, or on the calcaneus, sorry. I'll also evaluate it in long axis, and you can kind of see that plantaris tendon right up there. And a really thin tendon, it can be easy to fall off of that tendon. So you really want to make sure as you're rotating on it from short axis to long axis that you're really anchoring that probe down or that transducer down. Otherwise, you will slip off of it quite easily, and you could be over the Achilles tendon and not really realize it. A lot of times, I won't always evaluate that posterior tibiotalar or subtalar joint, but on her, I did. And that posterior tibiotalar joint, you have the Achilles overlying, a Kager's fat pad, and then you have the posterior tibia and that calcaneus coming in here, and that articular cartilage on the calcaneus, not an effusion. Then the subtalar joint, you definitely can see some fluid coming out of that subtalar joint. So this patient did have a subtalar joint effusion and likely some degenerative change there. But again, not a symptomatic thing on exam that I was able to reproduce with talar tilt or inversion eversion of the foot. And plantar toe walking was also asymptomatic at the time. So did not seem like that was a symptomatic source of her pain at the time. The plantar fascia I'll evaluate as well when we're looking at this heel pain and posterior ankle pain. You can kind of see the calcaneus here over the medial calcaneal tubercle. You see on this graphic here, we're in longitudinal view of that plantar fascia, and you're looking for that plantar fascia thickening. And there's kind of outlining the plantar fascia there. That central cord is what we're looking at here off the medial calcaneal tubercle. It rises from that medial calcaneal tubercle and attaches on that plantar plate from metatarsal 1 to 5. The thickness over 4 millimeters is generally considered indicative of plantar fasciopathy, but the important thing really is to look at both sides to compare the contralateral limb because they could just have thickened plantar fascia, and that might not be the source of their pain. You look for hypoechogenicity, any kind of nodular thickening, any perifascial effusion is also sometimes a more rare sign of a plantar fasciopathy. And then we look at it in short axis, and I scan from that insertion or origin of the plantar fascia distally, and you can see as it's coming up here, it's just moving a little bit distal, and just making sure that that's not thickening up really at all and staying nice and uniform and not hypoechoic or anything like that. Then we'll look at the lateral calcaneal tubercle coming in here on the left side of the screen, and then the lateral cord or of the plantar fascia. That'll kind of insert more at the base of the 5th metatarsal, and generally this doesn't cause as much heel pain as it does cause more pain similar to a metatarsal fracture, and it oftentimes gets confused with that. So I look at that in long axis and again in short axis, but I'm looking again for that thickening that's asymmetric side to side, hypoechogenicity, or any kind of fascial effusion. Then we're going to get more into the nerves here. So this is just kind of a little diagram of some of the peripheral and cutaneous innervations that we see for the sensory innervation of the foot and ankle. This green here is that medial calcaneal nerve. And based on the exam, this does fit really well with the distribution of where her pain does, kind of in that posterior heel and wrapping around to the undersurface. You do have that medial and lateral plantar nerve as well, but that supplies the sensation a little more distally in the foot. So the tibial nerve, kind of your home base, is in that retromalleolar groove. And as you can see on this diagram here, there's a lot of stuff back there, a lot of blood vessels, a lot of nerves, and you have all those tendons. So you have your posterior tibialis, your flexor digitorum, and then deep down is your flexor hallucis longus. Then you have your posterior tibial veins and tibial artery, and you have your tibial nerve here right under the laciniate ligament. As we're looking at that tibial nerve, you kind of see right here, we were scanning from higher up and down to that lateral or that medial malleolus. And at the end of the video here, you get that laciniate ligament coming in, that flexor retinaculum, but there's that tibial nerve right there. So that's kind of scanning from above the malleolus down to the malleolus. And then from that malleolus distally, you get down to that medial calcaneus, and you have this little sulcus or groove that FHL sits in right at the end of this picture. And that's where you start seeing the separation of the medial and lateral plantar nerve. So from here, that nerve is separating to the lateral and medial plantar nerve more anterior. And on these images for this area, the right of the screen is going to be posterior for all of these pictures. So then we're going to look at that medial calcaneal nerve. In this picture here, it can be a little bit difficult to see. And the important thing to know is with the medial calcaneal nerve, there's a lot of anatomic variation. Anywhere from 1 to 4 branches off the tibial nerve have been described in the literature. About 65% of the time, it does bifurcate from the tibial nerve above that flexor retinaculum in this patient on this side. For this image, we're getting the asymptomatic side, what we're seeing, and then kind of the pathology we'll see is a little in a couple slides, but about 90% of the time it does arise from within 1 centimeter of the malleolar calcaneal axis, which is a line between the center of the medial malleolus and medial calcaneal tuberosity. So what we see here, there's that tibial nerve outlined, and then there's that medial calcaneal nerve, which has slipped off. When we watch the video here, you kind of see that medial calcaneal nerve just above the tibial nerve, and it's staying right there next to that tibial artery right here. and then it's coming more posterior, and the calcaneal nerve will wrap posteriorly, kind of around the medial side of the heel and under the bottom of the heel. Baxter's nerve is the other one that it can get confused with, and that one's going to be a little bit more distal, a little bit more anterior, and it's going to go kind of deeper down between the flexor hallucis, or sorry, the abductor hallucis and the quadratus plantae, but we'll see that a little better here in just a second. And then this is another picture just of that medial calcaneal nerve, just coming more posteriorly towards that calcaneus there. And this again is on that asymptomatic side. Now this is the symptomatic side. I used a different transducer on this one, so a little bit different of an image, but this is coming from distal to proximal. And what you can kind of see here, it's a little blurrier, but the medial calcaneal nerve is right here. That tibial nerve is coming in as I'm coming superficial. You can kind of slowly see that medial calcaneal nerve coming in, and right in here, hypoechogenic fluid tissue. And that is where the pain was starting. She had direct tenderness to sonopalpation right in this area where this thickened tissue is, that dark tissue right around that nerve. And that is right as you see me coming up, you see that nerve kind of insert into the and bifurcate and come together with that tibial nerve right there. So that thickened tissue is what I was interpreting as some thickening and potential entrapment site of that medial calcaneal nerve. And especially compared to the other side, looks quite different. Then we look kind of at the lateral plantar nerve. We're seeing here, lateral plantar nerve, and a medial plantar nerve here. Lateral plantar nerve is coming more, so that's the lateral plantar nerve. Coming off of there is that Baxter's nerve coming this way. That lateral plantar nerve sticks with the lateral plantar artery, and it's going along on the undersurface of the foot. The medial plantar nerve more anterior here, so lateral plantar, medial plantar. The first branch of the lateral plantar nerve is the inferior calcaneal nerve, and also known as Baxter's nerve. As we're looking here, that lateral plantar nerve comes anterior. That Baxter's nerve is coming off right here, if you kind of see. So Baxter's nerve coming off right there. And then Baxter's nerve slipping down here between the abductor hallucis and the quadratus plantae in this tissue plane right there. Now, let me see if I can get a still of that nerve, excuse me, right there as we're coming in right about here for that lateral plantar, or that first branch of the inferior calcaneal nerve. And as I was tracking this nerve, no tenderness on sonopalpation to that nerve. So then finally, the last nerve we're going to look at is the medial calcaneal nerve. On this picture, you have lateral here, you have your medial plantar nerve here, so anterior to the left. And as we're following that nerve distally, you kind of see that hyperechogenic medial plantar nerve here, lateral plantar nerve here, and Baxter's nerve coming up under the artery over this way. We'll watch that one more time. That lateral plantar nerve sending the Baxter's nerve off right there on the other side of that posterior tibial artery. And that becomes the lateral plantar artery. So there's that medial plantar nerve. And you follow that down to that master knot of Henry, typically when you're looking for potential sites of entrapment. All right, so then the diagnostic report is the last thing we'll look at. So I usually kind of give a summary of who they were referred by, quick summary of the pain, and the history. We'll look at the laterality, and on this patient it was the left ankle. Procedure was a complete diagnostic ultrasound of the posterior ankle for posterior medial heel pain, comparing it to the left ankle radiographs. And the transducers used were a high frequency linear probe and a high frequency small footprint linear or hockey stick. The Achilles tendon, so in the findings, the Achilles tendon was intact and relatively normal in appearance. There was that small nodular thickening. The Plantaris tendon was again intact and normal in appearance to its insertion on the calcaneus. There was a small retrocalcaneal bursal effusion and retro-Achilles bursal thickening without hyperemia, but no pain on sonopalpation in these areas. Tibial nerve, artery, and veins were normal in appearance through the tarsal tunnel. There was thickening of the perineural tissue at the site of the medial calcaneal nerve bifurcation from the tibial nerve. And it was a reproduction of pain with sonopalpation over this location and then directly overlying the course of the medial calcaneal nerve. The medial and lateral plantar nerves and inferior calcaneal nerve were normal in appearance and without pain reproduced on sonopalpation. There was a subtalar joint diffusion, and tibiotalar joint was normal in appearance. So when we're summarizing the impression, there was entrapment of the medial calcaneal nerve. You want to summarize what you were seeing and really give a story about where the symptoms would be coming from. So there was entrapment of that medial calcaneal nerve near its origin off the tibial nerve, with reproduction of pain with sonopalpation along that calcaneal nerve. There was thickening of the retroachilles bursa and subtalar joint diffusion. And that wraps it up. So happy to take any questions or comments here.
Great job, Wade. Very thorough as expected. Your images are great. I thought, overall that was, exceptionally well done as expected. I just have a couple quick points to make. I have a question, and then, certainly Doug will chime in with some pearls. For me in this area, very similar protocol. Like I've mentioned and Doug's mentioned a million times, we usually start with the joint. This is one region for me, another region for me that I don't. I start with the Achilles just like you did, and pretty much follow a fairly similar protocol. When we are evaluating the plantar foot, in particular plantar fascia, just one quick comment to make because it drives me nuts. You describe the plantar fascia appropriately, and I think oftentimes we use incorrect words down in that area. So there's a central cord and a lateral cord, just like you mentioned. There's not a medial cord, there's a medial band. And so, knowing where we're at and what structures we're talking about is important, just like you mentioned. The other thing with the tibial nerve, like you said, the variability is all over the place. Classically, we like to think of tibial nerve coming down, medial calcaneal branch will take off, and then you have bifurcation in the medial lateral plantar nerve. But that certainly is not the case all the time. And I think, as you're scanning this region, rather than just memorizing, I think medial calcaneal comes off first, and then, the remainder of the nerve bifurcates, just following these nerves distally and seeing where they go can help in terms of nerve branch identification. It's interesting when we talk about tibial nerve compressive etiologies, we think about tibial nerve in the tarsal tunnel. We think about, like you mentioned, the inferior calcaneal nerve, primarily as it gets squished between adductor and QP. We think about the medial plantar nerve as it gets pinched between adductor and the navicular, but we really don't talk about or see a ton of medial calcaneal nerve pathology. And for this case, I'm curious, what structure do you think that nerve was getting compressed under? Do you think it was just hypertrophic subcutaneous tissue, or what was actually compressing that nerve in that region, do you think?
Yeah, so that pathology video I had didn't go higher up, but it was right. This medial calcaneal nerve on this symptomatic side arose just distal to that flexor retinaculum, and I think it was that thickened tissue. I think was just from compression right at that flexor retinaculum.
Got it.
Yeah, and that's ended up just like you said. There's so much anatomic variability, and even side to side on this patient, you saw the differences in how those nerves appeared. It is important, like you said, to scan all the different areas pretty thoroughly to make sure where that pain's coming from. But it also, because it's so variable, most diagnostic studies are hard to definitively say that this is the source of the pain. So this patient actually did undergo kind of a diagnostic and therapeutic nerve block hydrodissection procedure at that medial calcaneal nerve, just at that bifurcation, and had about 85 to 90% relief of her symptoms that was maintained about 3 months when I last saw her.
Great.
Yeah.
Awesome. Thanks, Wade. Doug, do you have some comments to make?
Yeah, nice job, Wade, as expected. So it's interesting, my protocols are fairly different. For this case, the protocol you present, Wade, is the exact protocol that needs to be done. Oftentimes, I'm not the one starting the scan, it's my sonographer. So, I have a plantar hindfoot protocol, I have an Achilles protocol, I have a medial ankle protocol. And so, any one of those would have worked. And my plantar hindfoot as well as Achilles protocol, I do include the medial tarsal tunnel. And of course, I included with the medial ankle. So it accomplishes the same thing, but it doesn't quite thoroughly investigate that small area as your protocol. But that's just kind of how it does. And I find that in a case like this, my experience has been, I pick a protocol, whether it's Achilles or plantar hindfoot, and the plantar fascia is normal. The Achilles is pretty normal in like your case. And then that's the red flag for me. Okay, what is causing the heel pain? And now I'm going to scrutinize the tibial nerve and its branches much closer. I'm going to look for other pathology that can give heel pain that's not apparent. So that's just my experience. And, just a little difference in protocols. Your case illustrates a lot of good things that probably, are obvious. I mean, one is that when you get a runner, you get an athlete who's 47 years old, you're going to find abnormalities. And so in your case, subtalar effusion, thickening of I call it the superficial adventitial bursa, or retro Achilles bursa. I mean, those are all things that we almost expect. There's the enthesiophyte there. And as you point out, the trick is exactly that, to decipher, what you think is pathology versus what you think is an asymptomatic finding. A quick comment on your Achilles, just for people who are starting out. On short axis of the Achilles, because you scan, proximal to distal, which is exactly what I do. There's a rotation to the Achilles. There's a rotation. So there's 3 bundles of fibers, one from the lateral gastroc, one from the medial gastroc, and then one from the soleus. The 3 bundles rotate around each other, as well as that there's interbundle rotation as well. So as people start scanning the Achilles more, you'll see that. The other thing I've noticed, and we haven't really talked about much, it's, other than maybe just a mild abnormality of the Achilles that you showed on your case, when I see more true Achilles tendinosis as a primary diagnosis, I rarely see a normal Kager's fat pad. So we don't talk about Kager's fat pad that much. I think in the future, we're going to talk about it more, as we'll probably talk about Hoffa's fat pad more in the knee. But that's just a comment because you included it. Finally, the tibial nerve, you again alluded to, I'm just going to state it for people just starting out. So my red flag is up because, they're having heel pain, and, you showed a normal Achilles, you showed a normal plantar fascia. I always start scanning that tibial nerve more proximally than I would if, for a typical, just get the medial tarsal tunnel as part of the protocol, for the reasons that you stated. There's such variability. And I'm sure that if the medial calcaneal nerve branched more distally, as most do, she probably wouldn't have had an impingement. But because it branched proximal to the flexor retinaculum, that's probably why it got impinged. So you're going to miss variations if you start the tibial nerve scanning in the medial tarsal tunnel. You got to start proximally. And kind of as is already alluded to, nerves are named for where they end up. And so there's a lot of nerves, coming off, and there may be more than one branches. So, the medial calcaneal nerve, ends in the subcutaneous tissue at the medial calcaneal wall, whereas the inferior calcaneal nerve is going to go, between the abductor hallucis and the quadratus plantae. So that's how you distinguish the nerves. And then finally, I've said this a few times, but anytime you're scanning a nerve and that nerve is not just pure sensory, you got to scan the muscle, just like electrodiagnostic studies. You do nerve conduction velocities, but then you should also, then you do an EMG. And it's the same thing with ultrasound. And so if I thought that in this case, the inferior calcaneal nerve was a culprit, then you need to include the abductor digiti minimi, the ADM, in that protocol to look at the muscle. And in this case, because it was the medial calcaneal nerve or pure sensory nerve, that wasn't required. But that's something that I think that we should all include when we're looking at nerves, is make sure we include the muscles. That's what I have. Any other comments, Wade? I mean, really good case. I mean, it's not something we see every day, but something we should think about.
Yeah, thank you, Doug, and thank you for the comments and some of those important points. I think you're absolutely hitting it right on the head, where you definitely need to be scanning not only the nerves but the muscles that they innervate. And because of that anatomic variability, yeah, you do need to extend it out. I tried to highlight on my one video, kind of going from kind of mid to distal tibia down to that flexor retinaculum along the tibial nerve, because I agree there's so much variability in that space. You do have to expand it out a little more when you have a more obscure case like this one potentially.
Right. And, again, for people starting out, if you notice, just about every time Wade was scanning these nerves, he was doing this dynamically. And so that's how you find him is keep the probe moving so your eye catches. And so again, if you're just starting out, Wade demonstrated exactly how you should do it.
Yeah, I agree with that completely. Nerves are going to change depth and change course, and fast transducer motion is really going to, like you said, Doug and Wade, get those nerves to to catch your eye and be able to better identify them, especially these small distal branches. All right, well, we'll wrap it there, Wade. Like I said, as expected, that was excellent. I really appreciate you coming on and doing this. As I anticipated, I learned something, as I do every time you talk. So thank you for doing that. I really appreciate it. As always is the case, we are off next week, and then we are back on the 14th. So Doug, our own Doug Hoffman, is going to be talking about a hernia protocol. Something not a lot of us do. When we're talking true hernia protocol. So I think this will be very high level and very, very high yield. So we'll see everybody back then. Thanks again for joining and for watching, for those that will watch on YouTube afterwards, and happy weekend.
Thanks a lot.
All right, see you guys.
Have a good one.